On our panel today, we first have a substitute. Dr. St. Goar is stepping in for Valerie Jo. She couldn't be here today.
They traded down.
Yeah, well. So we have our cardiologist who cover the emergency room here and provide cardiac care at El Camino Health. And their medical directors as well. Please let me introduce Dr. Raabia Ahmad. Dr. Ahmad is a general cardiologist. She is the co-director of the Heart and Failure Program. And I'd also like to introduce Dr. Anthony Ia. Dr. Ia is an interventional cardiologist who specializes in coronary and structural heart procedures. And Dr. Fred St. Goar is the medical director of Heart and Vascular Institute and has been a cardiologist in our community for 32 years. So we look forward to their discussion of
I started in high school, is that what you're suggesting?
Yeah, exactly.
Oh my God,
yeah, Doogie Howser,
please,
right? Dr. Doogie
seriously.
Howser, is that?
32. Josh, well, thanks. And thanks for the great introduction. There's actually going to be a test on everything that Josh said at the end, so I hope you all took notes, and we're going to be reinforcing it here as we talk through this. So as I say, the way we're going to work here is we're going to light a little fire here, so we have a fireside chat, and then I, as Valerie, I'm going to present a little bit of a typical scenario of a patient, and then just turn it over to you guys to sort of talk through how you would deal with it and what you're thinking, and I'll prompt you from time to time. But so the scenario it's a very typical one where it's a 65-year-old woman who has a history of mild hypertension. Her cholesterol's been a little elevated, and there actually is a history in her family of some heart disease, but she's otherwise been pretty good. She's been pretty active, and what she's noticed recently when she's been walking around, and even when she walks the hills, she gets a funny sensation. Her sensation is sort of a tightness up in her throat, and also in her left shoulder and arm a little bit, but nothing more than that, and it would always go away when she'd stop, and this was going on for a couple of weeks. And then she woke up one morning and she was sitting at the breakfast table, and that same sensation while she was at rest came on. And it was quite severe, and this time it was associated with a little sweatiness, and she was short of breath. And it abated a bit, but she just turned to her husband and said, "I need to go to the hospital." So what would you be thinking when this patient rolls into the emergency room and you were called to take a look at her?
So my first thought about this patient is that it sounds like she may be having a mild heart attack. And what her symptoms sound like is that she probably has a blockage that is a result of plaque buildup in the arteries. And at rest, most of the time she'd been okay because her heart was getting enough blood flow. As her heart sped up and she was exercising, her heart needed a little bit more blood flow, and that blockage was preventing her from getting enough flow to her heart muscle, which was resulting in some of her symptoms. That day, her symptoms became more unstable. The fact that they're occurring at rest makes me worried that there's something more critical going on and that something about that plaque has destabilized and that we need to do something sooner. So her coming to the emergency room was exactly what she should have done.
And then what would you, as she came into the emergency room, what would be sort of your thought process, and what might you sort of address in terms of your evaluation of her?
So, my first thought is, her symptoms. Her symptoms are not typical of what we think about when it comes to heart disease, which in women is kind of classic. And over 50% of women who present to the emergency room don't have the classic chest pain. Sometimes it's what she described, throat tightness, arm pain, nausea, sweating, abdominal pain, dizziness, lightheadedness, sort of vague symptoms that are not the classic elephant on their chest, heaviness, tightness that people classically think about when it comes to coronary disease. So I'm thinking about her symptoms. I'm thinking about, what are her risk factors? So for her risk factors, she has a family history, high blood pressure would be one question I ask, high cholesterol, diabetes. I look at the overall risk factors of that patient. And women in particular, I always like to ask about their history of their pregnancies. Did they have any complications such as eclampsia and preeclampsia, which we know increases the risk of coronary artery disease in women by over 50% in the future. So I always include that in my history of women in particular.
Preeclampsia being?
Preeclampsia being a complication that happens towards the end of pregnancy where the blood pressure goes up and there's certain abnormalities, and we think it has to it's a blood vessel issue with the placenta that kind of correlates with similar findings that happen with heart disease with the endothelium of the blood vessels. So I'm thinking about her symptoms, and then I'm gathering a history. Her history sounds pretty typical, as we mentioned, of heart disease. And the first test she would get is a EKG. The EKG in some of these cases is not always that diagnostic. It may be subtle changes. It may be completely normal because her symptoms had pretty much resolved by the time we saw her. So then we get some other diagnostic tests, usually a blood test or troponin, which is one of the cardiac enzymes that is elevated when people are having a heart event.
Why is that? I mean, we hear the word troponin and at the heart. What does that really mean? Is it something that if your blood pressure goes up, what is troponin?
So troponin is one of the cardiac enzymes that's released when the heart muscle is damaged in some way. So in heart attacks, classically, when someone first comes in with symptoms, it may be completely normal. So what we do is we do serial enzymes and check them at 2 hours and then 8 hours and look for a change, look for an increase, because it takes time for that to get elevated. But just because a troponin is elevated, it doesn't always mean that someone's having an active heart attack. It can be elevated in other medical conditions, such as kidney disease, or if someone's sick from something else, an infection, or has other things going on. So it's not always, the only tool we use, but it's one of the pieces that we use to put together a picture of what's going on with this patient. The other tests we use would be sometimes an echocardiogram, an ultrasound of the heart, looking at the heart muscle, which I know we're going to see some examples of in the future, and looking at is there a part of the wall that's not moving that would suggest a loss of blood flow to the heart muscle in that area. So we put together these tests, and sometimes we include CT of the coronaries and stress tests if it's not totally clear what's going on with this patient.
How good is an EKG? I know everyone walks in the door of the emergency room, and the first thing someone says, chest pressure or something, boom, they get an EKG. How good is that for diagnosing a heart attack, and what are they looking at there?
So with the EKG, they're looking at the electrical conduction to the heart, and there's certain characteristic findings we see in someone having an acute heart attack. If they have a total blockage and their artery is completely blocked, there's some classic findings that is kind of a slam dunk diagnosis in some cases. But in most cases, it may be more subtle. It may be just some subtle electrical changes. It may be completely normal. So it's not the only piece of information we use. It's one of the things in our toolbox.
And when we look at an EKG, these little bumps and things like that, what does that represent? I mean, what are we looking at?
So an EKG is looking at the electrical signals of the heart, and it's looking at the different depolarizations of the heart as the heart's contracting. And so there's certain areas of the EKG, which we'll see an example in this case coming up, but we'll see an example that shows what a heart attack is, and we see changes based on if someone is losing blood flow. And
so they're classic sort of footprints for a heart attack versus other abnormalities?
Exactly.
Nice. So you did an EKG, and it's not totally diagnostic, but suggestive. What's your next thought process?
So I get the history, I get the blood work, I get an echocardiogram, and it seems pretty clear to me that this patient probably is having an acute MI based on their blood work and everything. And so we start medications. The first step we would do is start medications. Usually aspirin would be the first medication they get, and some other form of blood thinner like heparin or Plavix is usually involved. And what that does is dissolve any plaque, any clot that may be around that plaque that's become unstable, that's resulted in this patient suddenly having a loss of blood flow.
So can you explain that? So you're giving a blood thinner. I mean, I thought blocked arteries were just plaque filling up and just sticking it. What is the clot involvement with that?
So basically, the plaque buildup is the etiology of the heart attack, the plaque based on high cholesterol and other factors in the blood vessel that leads to the narrowing. But what usually causes that plaque to suddenly become unstable and someone to develop more severe heart disease would be that rupture of that plaque. And when that plaque ruptures, something causes that plaque to become unstable. Usually it involves a blood clot around that plaque that results in that sudden, symptoms at rest and loss of blood flow. And so that's where the aspirin and the blood thinners come in. They help dissolve that plaque and stabilize that plaque.
Interesting. Good. So it's occluded, obviously, if it's totally, and there's a pathognomonic sign there, is that footprint for the heart attack occurring. what would be your next step at that point?
So at that point, I'm calling my interventional partner over here, Dr. Ia, and I'm talking to the family and explaining to them that we probably need to do a coronary angiogram. And
Can you explain that? Well, I mean, because that's kind of a nerve-wracking thing when you're told you have to have an angiogram. That sounds
Yeah.
kind of scary.
so the angiogram, I usually let Dr. Ia go through all the details, but my assessment is, I tell the patient, you're going to have a test where we insert a catheter to the vessels and we take pictures of the blood vessels. And hopefully, if we find a blockage, we can treat it with the stent as part of the same procedure. And I'll let Dr. Ia show us.
Okay, here comes the cowboy. He's coming flying in on his stallion. He's been told someone's having a heart attack. And you meet the patient either in the emergency room or maybe even in the cath lab. And what's your initial quick conversation with the patient?
Well, I let them know why I'm there and why we are doing the procedure in the first place. Usually we say your EKG has signs that you're having an emergency heart attack and time is of the essence. When time is of the essence, me and several other cath team members rush in. We get there as quickly as we can, usually within 30 minutes, and we tell them, this is the procedure you're gonna have. We're gonna go into the arteries of the heart, we're gonna find where the blockage is, and if we can fix it with a stent, we're gonna fix it with a stent. Sometimes people ask us, how long is this gonna take, doc? I say usually about half an hour to an hour, depending on what we find. And they ask, well, what happens afterwards? And say, well, you probably will need some new medications to prevent this from happening again. And then they usually ask, well, how long will I have to be here? Generally about 1 to 2 days, depending on how quickly they heal.
So you used a couple of terms. You used the term balloon, you used the term stent. You're fixing it with stent. What is the difference there, and what are the implications? And as a patient, should I be worried about one versus the other or know more about one than the other? I guess we're
Great
gonna
question.
get it here. You can talk through this as we're doing it.
So this is a picture where a catheter or plastic tubing is pointed into the artery of the heart. There is highlighted a blockage or a narrowing, and through that narrowing, a wire will be fed through under the guidance of continuous X-ray so we can see it. This balloon here expands where the blockage is. Blood can now flow normally and feed the muscle of the heart. And then to keep this blockage from reoccluding or having tears, we put in a stent. This stent is made of metal, it's coated with medications, and this helps to scaffold that artery that was just opened up with a balloon. And so that procedure requires a little bit of contrast. So we talk about the implications of what that can do to your kidneys. We try to use as little as possible. And we would enter with the smallest needle possible, usually in the artery at the wrist or at the hip. And that allows us to do this procedure with as minimally invasive as possible. And if we're fortunate enough where there's only one artery that needs to be fixed, well, we typically fix that with a stent. But if we have other information, like someone is a diabetic or that their heart muscle is weak from multiple blockages, we have other discussions about treatments that may be longer lasting, like open heart surgery. I often say we don't know what we're gonna find until we get in there. Depending on the damage or the blockage, it may be like a flat tire that has one nail in the middle of the tire. Well, we can patch that up. The tire's as good as new. If there are 5 nails in that tire, you need a new tire.
Are there any other questions that the patient should ask before they go off? Like, have you done this before?
I usually tell them I watch a YouTube video before we get started.
Perfect. No, I want to open up for some questions here, but before we do, there's one thing to actually put in perspective for some of you here. This will make more sense than others just because of your generation. But in 1955, when one President Eisenhower had his heart attack, he was out on vacation. He ended up spending 6 weeks in the hospital, and before going back to the White House. And his mortality, his chance of dying in 1955 was over 30%. When that happens today, what's the patient's chance of making it out alive, and how quickly do they get out of the hospital?
More than 90% that they'll make it out alive, which is a dramatic improvement, closer to 95 to 98%.
98 is what I've heard.
And they're
yeah.
getting home within 1 to 2 days. rather than
Put that
staying
in
the
perspective.
hospital.
That's in all of your lifetime, most of yours in the room lifetime. That change is just remarkable. And it's kudos to amazing amount of innovation, amazing amount of work by people like these two here who've really sort of set the standard for how this is taken care of. Now, this is supposed to be a conversation, so let's light the fire here. And does anyone have a question? Now, as you're thinking about your questions, here, I'll take it. As you think about your questions, if you could make them kind of general, don't have them specifically about your care, because if you do that, that's probably better just to go to your own doctor. But think of general questions would be, and then things that we could supplement. You had your hand up first, please. Yeah.
You are correct. It would not, the stents are MRI compatible, correct.
You
It
turn
depends.
on the MRI and they pull them out of your body. No.
You can have lots of stents and still have an MRI, thankfully.
Yeah. Great. Yeah, please.
Okay, you got it. So they don't go through the groin, is that not done anymore?
That's a great question.
Okay.
So we prefer to go through the wrist more contemporarily because it's safer, it's easier to control complications. We will often go through the groin if the artery in the arm is not the best suitable, either it's too small or the bends in the arteries getting to the heart are incompatible. So yes, we can do both now. We tend to favor going through the wrist for safety.
So we're talking to a big forum here. There's a bunch of people out there in inner space who are watching, and I want to thank them and acknowledge them and ask them to also send in questions because we have an all-star team. And Kathleen, maybe could you transmit the question that you've heard?
So this is a good one. It is, why do women present differently than men when they have a heart attack? Are their hearts different somehow?
I don't know that their hearts are different, and I think that's something.
They're
Kinder.
sweeter. Come on.
They're kinder.
Yes, women are better people. So women, just classically don't have those typical symptoms. It's just something about women's hearts that their sensations are slightly different. So sometimes women just have some fatigue, some lightheadedness, some nausea, some abdominal pain. So we don't exactly know why, but I think we have to be educated to know that, and in the past we may not have been so educated, that it's not, we have to just have a high level of awareness. And that women's heart disease, women have the same heart disease as men. It's the same process, it's the same thing, but we just have to be more aware of that their symptoms are different and that their risk factors may be a little bit different.
So does a 50-year-old woman have the exact same risk profile as a 50-year-old man?
I would say, probably yes. Family history plays a big role, genetics plays a role. Women, classically people think women are protected from heart disease. That protection we know goes away towards the end of menopause. That within that time, the risk factors, the estrogen has some benefit to women in preventing heart disease in the time while they're menstruating, but post-menopause, women have exactly the same risk factors as men.
Questions? Thank you. Yes.
It's me. Okay. A history, a female, 85 years old, had a heart attack 10 years ago. Reoccurred about 3 weeks ago, was transported to Stanford. Helicopter came and picked her up. Stanford kept her for 2 weeks, and now she's at the Lodi Rehab Acute. And it was diagnosed as an aortic dissection, which I did not understand.
Wow, that's a good question, and that's a big question, a little different than what we're talking about. Do you want to briefly, though, just explain the difference?
Yeah, an aorta dissection is actually the big blood vessel that leaves the heart. So it's not the blood vessels that nourish the heart. So that's not a blockage feeding the blood vessel to the heart. It's the blood vessel feeding the rest of the body from the heart. So that's a different problem than a heart attack or someone that has a blocked artery that needs a stent.
But sometimes the symptoms can be somewhat similar. So chest pain, back pain. So one of the things we always want to rule out when someone comes in with chest pain before we necessarily go through an angiogram is whether they have an aortic dissection.
Very good question. Question behind? Yeah. Can you use a microphone?
Yeah, sure. Hi, thank you very much for this. My name is Dhaval. I'm talking about, you showed that procedure of stenting. Is it possible, if there's some calcified plaque, which is hard plaque, is it possible to also clean? Because I thought there's some blades you can put in and do some. Can you elaborate on that part also, the cleaning part?
Yeah, sometimes the plaque is not soft. It's calcified. It's almost rusted over. And so it's not so amenable to just a balloon modifying it. Sometimes they need further treatment before a balloon can expand it. In those cases, we have several tools all available here at El Camino. There are lasers that can actually help to break it up. There's actually like tiny drill bits that will wear down that plaque. There's even balloons that emit ultrasonic energy that will break the plaque, just like we use kidney stone energy for. And so if a plaque has that hard, resistant calcification, we will need to pre-treat by wearing that calcium down before we can expand it with a balloon and then prop it open with a stent. That's a great question.
Anything back there, Kathleen, from the remote?
So how long is the life of a stent? And how do you know if it's in perfect condition or not, say, after about 8 years?
Oh, that's a good question, and one we get often. So the life of the stent is as long as the life of the person. We expect it to be there the entire time. It doesn't wear down, it doesn't degrade, but a stent won't prevent a heart attack from happening. The same problem that required the stent to be there in the first place can happen again. And so that's why it's so important to take your medications, eat healthy, exercise, maintain a healthy body weight, stop smoking, and going to the prescribed rehab to help you recover from it. So the stent is there to treat the problem you had, but it's not going to prevent other problems from happening down the road. If it did, we'd be stenting everybody's arteries before they even had a problem, and I'd be very busy and happy.
What causes the plaque to harden?
So the plaque is usually a result of cholesterol. So high cholesterol plays a big role in that, but that doesn't mean that everybody who has a heart attack or has plaque has high cholesterol. There are other factors that weigh in, which are genetics. Some people are just more prone to plaque buildup. Smoking contributes a lot. So people who smoke, we know, build up a lot of plaque in their arteries. And so we know that people have plaque. Just because you have plaque doesn't necessarily mean that you end up with a heart attack, though. We do things called calcium scores, which we use as a risk stratification to say that you have some plaque in your arteries. How do we prevent that plaque from progressing? And usually we use medications to treat that, and the biggest one is statins, and controlling the cholesterol, quitting smoking, controlling blood pressure, controlling diabetes. All of those play a role in plaque buildup. And just because someone has plaque doesn't mean they inevitably are going to have a heart attack, but it's really a focus that we need to get your risk factors under control and do everything we can to prevent that plaque from progressing to a heart attack.
Right, and when we see calcium in the plaque, that means it's been there a long time. That's sort of the end stage of progression. If plaque starts as soft, it's very active, and then it fibroses, and the final beyond fibrosis then is true calcium. So if there's calcium in the artery, it's probably been there a long time, and truth be told, we all have plaque in our arteries.
We do.
There's just a lot of things we can do to keep it from progressing to that point. Yes?
So you briefly mentioned about diabetics and the stent. Can a stent be used on diabetics?
It can, absolutely. And personally, my father has diabetes, and so I often think about him when people are having their procedures. What would he be going through? And diabetes doesn't preclude getting a stent. It's just that some patients, if they have multiple blockages, they will have a longer treatment outcome or better outcomes with other treatments. Sometimes open heart surgery gives you a longer lasting treatment benefit and can sometimes prolong your life more than a stent could.
What does the risk of being a diabetic have?
Wonderful.
Yeah. So diabetes is a huge risk factor for heart disease, to the point that we treat diabetes as actually equivalent to having heart disease. So people who are diabetics, we want to control their cholesterol and keep it as low as possible, the same way we do with people who've had previous heart disease. So we know it's a huge risk factor for heart disease.
So part of that is just that the level of sugar or glucose in your blood is actually at a certain point becomes toxic to the lining of your vessel. It's called the endothelium. And when the endothelium needs to be normally function, and if there's circulating toxicities like glucose, that endothelium malfunctions, and that's when you start this prolonged and very dangerous process of plaque accumulation. Yeah, good question. Here's one.
When you do a breakdown of heart plaque, what are the risks of that plaque taking an excursion you don't want?
Oh, great question. That happens about 1% of the time, which is why we are very conscientious of when it's worth taking that risk of complications like that. Thankfully, though, most of the time, the plaque will stay embedded in the wall and won't go down through the rest of the artery. So that happens infrequently, thankfully. If that does happen, we have mitigation strategies, stronger medications to thin the blood so that it can continue passing through and to open up the blood vessel and the arteries.
That's a great question, and one that we get regularly, because it's just amazing to think that you're putting balloons and stuff like that down these vessels and stuff doesn't get shattered everywhere. Kathleen, is there any sort of final question from the back?
There was a question on statins, basically. Don't statins prevent the further buildup of plaque? And there was also one sort of related about the restenosis rates of the stents themselves.
So statins are probably our best tool that we have in preventing plaque buildup and treating coronary artery disease. So statins have two roles. One is lowering the cholesterol, which in turn, lowers the risk of plaque buildup. So we really, when people have had heart disease, we want to keep the cholesterol as low as possible, and we have lower targets to keep it at bay. The other thing statins do is they also cause plaque stabilization. So, the plaque that we mentioned, unstable plaque, is what causes a heart attack. We talked about blood thinners and aspirin in playing a role there. The statins themselves have a plaque stabilization effect as well as an anti-inflammatory effect that helps prevent plaque progression and restenosis of stents or new blockage forming within arteries. So statins play a huge role and are our best tool, and probably why our secondary prevention of heart disease is so much better than it used to be, because we really target that. If people don't tolerate statins, there are alternative medications that we have that are just as good and contribute as well. So it's not just statins, but we have a lot of medications to work for that.
That's great. That's really helpful. So those are great questions, by the way, everyone. We're getting the hook here. We want to move on to our next, but I hope this was a great start for the morning. You guys did a tremendous job, Anthony and Raabia. I think that I hope you all have a little more to think about, and when you go to your doctor now, you have a little more information to work off of and ask important questions. So with that, thank you guys, and I'm going to turn it back over to Josh.